Thank you, Chairman. Ladies and gentlemen, good afternoon. First of all, I would like to sincerely thank Dr. Androgiannakis and Prilakis for this kind invitation to this wonderful meeting. The most common disorders that we look for by using imaging include tendinopathy with or without impingement, partial or full thickness tears, reactive or overuse subacromial bursitis, and hydroxyapatite deposition disease. So in the next few minutes, I would like to present the plain radiographs, the value of plain radiographs, of ultrasonography and MRI, and in the end, I will give a couple of comments regarding MR arthrography. So first of all, we start with plain radiographs. Plain radiographs provide a global assessment of the shoulder, not only of the glenohumeral joint. They are also useful in the postoperative evaluation. And sequential radiographs are very useful also in long-lasting rotator cuff disease. If you need to use just a single view, the most valuable one is the true IP or Grassi view, where, as you can see, the patient is with the back attaching the X-ray detectors, and the thorax is switched about 30 to 40 degrees with respect to the painful shoulder. This is the Grassi view, and this is how we evaluate the acromiohumeral distance, starting from this sclerotic line over there, and the uppermost part of the humeral hand. This distance has to be between 9 and 10 millimeters normally, whereas if the distance is 6 to 7, we have at least partial tear of the supraspinatus, and if we have less than 6 millimeters, then it's probably a case of a full thickness tear of the supraspinatus. But we can also have increased distance, and the increased distance occurs when we have lipohemorrhon. As you can see here, this is a level, fat, fluid, because of a fracture of the surgical neck. And in this case, we have lipohemorrhon again as a result of a fracture and anterior dislocation. It's always useful also to compare current views with previous ones. For instance, this patient had calcific tendinopathy back in October 23. He had ultrasound-guided irrigation and removal of the calcific deposits, but there are some new symptoms now, and as you can see in the newer radiograph, we have some flecks of calcifications, but they are not the cause of pain. Actually, this patient turned out to have a frozen shoulder. In long-lasting disease also, it's very useful to have plain radiographs. Here we see that there are subcortical cyst formation, the humeral hand, also in the glean. We have osteophyte formation, joint space narrowing, and decreased distance in the acromiohumeral space in keeping with rotator cuff arthropathy from long-lasting tear. Let's move now to ultrasonography. What makes ultrasonography so important, so special in the shoulder area? First of all, we radiologists see the patients face to face, and this allows us to to extract information from the history. We can make a rough clinical assessment and clinical tests with the ultrasound, and in the end, the ultrasound evaluation may result to a final diagnosis. We can also suggest US-guided injection therapy at the same time, and therefore ultrasound can be a one-stop shop. Here you see very nicely the long axis and the normal ecotexture of the supraspinatus tendon. This is the log axis view. That's the cortex, that's the articular cartilage, whereas in tendinopathy we have impaired and altered ecotexture. You see higher and lower echogenicity here, together with fluid accumulation into the subacromial bursa. We can see also very nicely partial tears. As you can see here, this is intrasubstance tear, articular surface tear, or partial full thickness tear on the anterior aspect of the supraspinatus, all full thickness tear throughout the whole diameter of the tendon, as we see here in this oblique sagittal view. In addition to the static images, we can also evaluate clinically the impingement, which is a clinical test. It's not a radiological test, but with ultrasound, it can be both. Here you see the supraspinatus tendon, that's the shadow of the acromion, and we can see very nicely that the tendon moves very easily and smoothly under the acromion. There is no impingement. The same is true also with the subscapularis tendon. Here you see that, I wonder, yes, it works. Here you see very nicely the subscapularis tendon moving, no, that's the subscapularis, but it refuses to work. This is the coracoid process, so we can assess the subcoracoid impingement if it's present or not. Rotator cuff tendinopathy or partial tearing is very often complicated with subacromial bursitis, as you can see here with fluid accumulation. A couple of years ago, our team published a paper on the value of increased volume of injection. So instead of injecting just 1 ml of steroid, we can inject 1 ml of steroid together with 4 ml of long-lasting anesthetic and 5 ml of saline, and this shows much better results regarding the outcome. US-guided irrigation also is very popular and very efficient clinical. Here you see the calcific deposits, a large calcific deposit. Our group again has published a few papers on the outcome of the patients, and the outcome is very good. We evaluated the VAS and the DAS score, and the only perhaps negative predictor of a not very satisfactory outcome has to do with the involvement of the osseous structures, the intraosseous extension of the calcific deposits. So here I will show briefly with a couple of videos of what we do. This is the initial injection of anesthetic into the subacromial bursa. Then we move to a thicker needle. This is a thick 16G. We see the calcific deposit. We inject into the central part of the deposit saline and inject saline, aspirate the material, as you can see, with pumping movements. And this is the macroscopical result. You see how the material is removed from the calcific deposits. And in the end, we have to do with a cavity. That's a very good end result, a cavity. This cell of calcification surrounding the cavity is not important, it's not causing symptoms, and in the end of the procedure, we inject into the subacromial bursa the large volume that I previously shared with you. Here you see the injection into the subacromial bursa. Few words now about MR imaging. MR imaging is expensive. The availability is not as good as with ultrasound. It's a second-line examination, therefore, it is an examination where we do not have conclusive ultrasound with or without clinical assessment. What MRI can show is fatty muscular atrophy. This is very important to orthopedic surgeons in the preoperative planning. We may assess the intra-articular structures, which is difficult with ultrasound, the bone marrow, which is impossible with ultrasound, and also we can assess adhesive capsulitis. Here we see two cases with tendinopathy, high signal intensity and thickening of the subscapular tendon with bursitis, and in this oblique coronal view you see the thickening, high signal intensity again with reactive bursitis. We see also very nicely, particularly with high field systems, this is with 3 Tesla system, you see the partial tear, articular surface partial tears. In this patient also we see this thickening of the subscapular tendon with increased signal intensity in keeping with tendinopathy, and we have also extensive subacromial bursitis. A couple of examples: rim rent, anteriorly tear with some reactive bone marrow edema, concealed or interstitial tear, another rim rent tear, another interstitial tear, but in this patient we see also that there is a large calcific deposit with edema surrounding the calcific deposit, and therefore this is active, this is the cause of pain, together with the increased signal of in the subacromial bursa in keeping with bursitis. We see also that there is thickening of the wall, which is responsible for the inflammatory response. In massive rotator cuff tears, as in this case, we see the supraspinatus, the infraspinatus, teres minor. We are always focusing on the oblique T1-weighted sagittal images, where we can see that there is fat infiltration of the supraspinatus, infraspinatus, and particularly the teres minor, whereas the subscapularis muscle is robust. There is no fatty infiltration. Sequential MR images in a patient show that at 0 time, when we have the tear of the supraspinatus, the muscle overrides the tangential line. 38 months later, we see some atrophy, and 45 months later, we see that there is significant reduction of size with fatty atrophy of the supraspinatus muscle. In general, atrophy of the muscles occur with full tears. And a question regarding MR arthrography, which is very efficient in instability. Is there any role regarding the rotator cuff disease? The answer is yes. In elite athletes, overhead athletes, where we do have the posterior superior impingement syndrome. In this syndrome, we have migration of the humeral head posteriorly, and we have impingement upon the posterior superior labrum. And as a result, we have 3 important findings: subcortical cysts, labral tear or degeneration, and small tears in the other surface of the infraspinatus muscle and tendon, or the posterior part of the supraspinatus. So in conclusion, we always start with plain radiographs. They are very useful. Ultrasound can be the one-stop shop. MRI and MR arthrography are useful in more complicated cases in preoperative planning and in elite athletes. Thank you very much.